Good afternoon, dear colleagues. On the 17th of February 2025 at 5 p.m. afternoon, it's my pleasure to introduce Professor Guillaume Chassagnon and Professor Georg Langs to you. Different from a normal setting, in this case, I will speak very, very little. The reason why we are here together is a presentation that will be given by Professor Chassagnon in a minute or so. That was in a longer version already given in a context that is the following one. There is a Christian Doppler laboratory for machine learning-driven precision imaging here in Vienna. I have the privilege to be one of the scientific partners of this, and Professor Georg Langs is one of the two heads of the research unit. The other one is Professor Helmut Prosch, who is hopefully also joining in a later moment of this conversation today. I invited Guillaume and Georg to discuss the topic of the laboratory a little bit more in detail for this audience here today. And this is also the reason why I'm handing over right now to Georg to steer us through this for the next 20 to 30 to 40 to 50 minutes. Please,
Great.
Georg.
Thanks a lot for the invitation. It's really a pleasure and honor to be here. I'm also really happy to introduce Guillaume, but before I do that, I'd like to spend a few words on the Christian Doppler lab. So the Christian Doppler lab is focusing on machine learning in cancer imaging, and I think it's really a wonderful combination of different disciplines trying to develop new ideas, how we can treat cancer better and how we can diagnose it better, and also how to bring it into practice. And together with Professor Forgo, with Professor Prosch and myself, we are basically bringing together the disciplines of medicine, of radiology, law, and machine learning, so technology development together in this lab, because we believe that that's not a matter that should happen basically after development has finished. We try to figure out how we can implement this development in practice, but really the development of new technology, the ideas about how they can benefit clinical practice and what are the kind of circumstances that allow us to develop this novel technology and also apply them in clinical practice. I think we should all do that at the same time. And so in this Christian Doppler lab, we are really glad to work together with Professor Forgo and many others. And so with that, I'd like to introduce Professor Chassagnon. He's full professor of thoracic radiology in Paris. He's also the president of the Thoracic Imaging Society of France. And he's known in the field for several things. Me personally, I was very impressed by, he found or published one of the first papers during COVID, which really brought a big cohort, a big population of patients together to understand what are the diagnostic signs and how can we use machine learning in order to diagnose and guide treatment in this disease. And I think that's a big accomplishment, because it's not only about development, but also about bringing medical experts and technical experts together and organizing the community to create such a data set. And Guillaume is deeply involved in the implementation of artificial intelligence in the clinic. And that's why I'm really looking forward to his talk. For those of you who are not directly from the field, there is one area which we are concerned with, which is developing the technology, but we realize that bringing this technology, this complex technology, into the clinical workflows, making it happen in a way so that patients benefit from it and that there is more quality in the diagnostics, more speed in the diagnostics, is really a challenge in itself. And Guillaume is active in both of these fields, in the development, but also in the implementation. And so I'm really looking forward to the talk, and I'll hand over the stage to you.
Thank you very much, Georg. So thank you very much for the invitation. And in the upcoming minutes, I will try to speak about AI in lung cancer and what are the current application and perspective for AI. So these are my conflicts of interest. So first, a few words about lung cancer. You may know, but lung cancer is a leading cause of death from cancer worldwide. The incidence of lung cancer is 470,000 new cases per year in Europe, meaning that there is almost one new case every minute. So it's a very frequent cancer, and the 5-year survival of this cancer is very poor, only 13%, because most of these cancers are diagnosed at an advanced stage. So there is a lot of room for improvement. What is the treatment of lung cancer? The treatment is ideally surgery if it's possible, but if it is not possible, then it goes to chemotherapy, immunotherapy, or radiotherapy. So what we aim for patients with lung cancer is to have surgery. One of the main advances in the last decade about lung cancer is lung cancer screening. The first paper about lung cancer screening using a chest CT scan has been published in 2011. It was on a US cohort, a North American cohort, and in this paper they shown that doing lung cancer screening, a relative reduction in mortality of 20%, which is very important. And these results has been confirmed in Europe in this trial that has been published in 2020. So now we know that lung cancer screening can be very helpful to decrease mortality related to lung cancer. When it comes to lung cancer screening, what we are looking at are pulmonary nodules. Nodules are small dots that we can see in the lung, and what is very important is that these nodules are very common in the lung. And in fact, when we look at patients with involved in lung cancer screening programs, we can see that there are lung nodules in many patients, and most of these nodules are benign, meaning that only more than 88% of these nodules are benign. So we have to differentiate between malignant and benign nodules. So having nodules does not mean that patients have a lung cancer. Sometimes these nodules can be very difficult to diagnose or to detect on a CT scan, even by trained radiologists. And this is an example here. You have these small nodules that is here in this red circle, and this can be misdiagnosed by radiologists because it's very close to the cells. So we know that we need help, and there are several ways to help radiologists, and the first one is to use AI. So we had in the early 2000s, we had the first AI tools to detect lung nodules, which are what we call CAD systems, so computer-aided detection systems. And this first CAD system were based on classical machine learning approaches, and we will see the difference with the new one. We know that when we use this computer-aided detection system, we are better than when we perform double reading. So one radiologist plus AI is better than two radiologists reading the same examination. It has been published more than 10 years ago. The problem with this early CAD system is that they are associated with a lot of false positives, and so to detect nodules, you will have to check a lot of detections that are not nodules, so it costs a lot of time, so it's increased reading time. And also what we know is that for some types of nodules, which we call subsolid nodules, these tools are not very efficient. So they have a lot of false positives. They cannot detect all the types of nodules and they increase the reading time. So it's why there was some room for improvements, and now we are going to see the possible application of AI, and for this I mean new AI and especially deep learning for lung cancer screening. So first application is to use AI for detection task. The second one is to use AI for characterization task, and the last one is to use AI for prognostication. So first, for lung nodules detection, we saw that we have a computer-aided detection tool for years, and now with deep learning, we know that we can do better. So deep learning is more efficient than classical machine learning methods, and this is one of the many papers that shows that when you use deep learning, you are able to produce very efficient CAD system. Here, you have a sensitivity which is higher than 90%, and you only have 2 false positive per CT examination, so it allows to save time and to detect more nodules than with classical machine learning methods. Now we have several tools that are commercially available using this deep learning based computer-aided detection system. So AI can be used in the clinical routine to detect lung nodules. The second task for which we can use AI for lung cancer is nodule characterization. So now we know that we detected the lung nodules, but we need to know, is it a lung cancer or is it a benign nodule? And we saw that the majority of these nodules are benign. The first possibility is to use radiomics. What is radiomics? Radiomics is the combination of, it's a way to use classical machine learning methods to evaluate a lesion on radiological images. So a specificity of radiomics is that it first needs a first step in which you have to draw the lesion on your images, and then it will extract some characteristic to describe the images and the lesions, such as what is the size of the nodule, what is the shape of the nodule, what is the texture of the nodule, and then AI will just be used at the end to compute models with these different features. So radiomics is very specific because it is not able, AI is not able to see the images. It just takes into account characteristics that you use to describe the lesion. But by using this radiomics, you see here in a paper, we are able to predict if the nodules are adenocarcinomas or granulomas, meaning lung cancer or benign lesion, with AUC of 75 to 80%, which is very good, but it's not sufficient to be used in a clinical routine. If we use deep learning, it's different. Here in deep learning, you don't need to describe the image, you just give the image to the algorithm, and the algorithm is in charge of reading the image and providing the prediction of is it a benign or is it a malignant lesion. And when you do this, what we know is that to train the deep learning network, we need more data. So it's not based on hundreds of images, but it's trained on thousands and tens of thousands of lesions. But when you are able to do this, you get better performance. And here it's what is shown in this paper. Using deep learning, they had AUC of 84 to 92%. So meaning that it was better than radiomics. But still, in the two approaches, it was based on lung nodules that you previously detected, meaning yes, you have to show what are the nodules, and then it will tell you that, okay, this nodule is benign or malignant. But the aim, the ultimate goal for lung cancer screening is to have an automated screening, meaning that you just give the whole CT examination and it will tell you does the patient has or not lung cancer. And this is the purpose of this paper that has been published in 2019. This was published based on one of the data set of the lung cancer screening programs that shows that demonstrated the utility of lung cancer screening. So it's this NLST data set, a lot of cases, 42,000 CT scan. They use deep learning, and what they obtain is a model that has an AUC of 96%, so even better than what we showed before, to predict if the patient has a lung cancer or not. And what is very interesting in this paper is that the authors also trained the network to do the same thing as what radiologists do, meaning that to take into account the previous CT scan. And when the deep learning model was taking into account the previous CT scan, then the performances were the same, but were on par with radiologists, meaning that when you only have access to one CT scan, then it's better than radiologists. But when you do, as radiologists do every day, meaning comparing images with a follow-up, then it's not better than the radiologist. We can also use AI to do some other tasks of characterization, such as to try to predict the invasiveness. So is it a bad or a good cancer? To try to predict the EGFR mutation. So these are some type of mutation on which you can use specific chemotherapy. So here again, you see that you are able to depict a signal, but AUC are around 71 to 75% for all these diseases, meaning that there is a signal, but it's not enough to use it for clinical routine. And last task is prognostication. It's like crystal gazing. You aim to try to predict something from the images, such as what is is the patient going to respond or not to treatment. There are many patients, especially on immunotherapy. Why? Because immunotherapy is a very expensive treatment, and we know that only 30% of patients will respond to this very expensive treatment. So this is one of the several papers which use radiomics to try to predict the response to immunotherapy. So it was radiomics. They first drawn all the lesion on the CT scan, and then they extracting features from this lesion, and then they provide all the features to an AI model, and then they add a model that had an IUC of only 67%. It's quite good. We are very happy with 67% of AUC, but it's not enough to decide whether the patient should receive or not immunotherapy. So, what are the current clinical applications? We saw a lot of research, but how can we use AI in clinical routine? If we want to use AI in clinical routines, then it deals with money. We have to think about what are the justification for using AI. The first justification for using AI is because humans are being fallible, and we know it. It's also to improve patient prognosis. And the last justification is to increase productivity, because you will have to pay for AI, and so you have to get something from AI for the one who is paying for AI. So radiologists are fallible. We know it. I told you before, we know that when we use AI as a second reader, we are better than when we use two radiologists to read the same images. So radiologist plus AI is better than double reading, we know it. Also, we know that performances of radiologists are not constant. We know that when radiologists are tired, they become less efficient. And this is a very nice paper which show how the fatigue impact radiologists. They compare the performances of radiologists at the end of an overnight shift and at the end of a normal workday. And here you see that the visual pattern research is very different between the yellow one, so a normal workday, and the pink one, the purple one, sorry, after an overnight shift. And you see that it's very well organized at the end of a normal workday, whereas when you work all the nights is very unorganized. And also we know that the performance in this paper, the performance were less when radiologists were tired, and also what they found is that there was a longer viewing time. So it's bad to be tired, and also for radiologists, because when you are tired, you are not very organized, your performance is decreased, and you take more time to achieve a diagnosis. So second justification is to use AI to improve patient prognosis, and this is very difficult to demonstrate that AI can improve patient prognosis, but from the data we have from lung cancer screening program, we know that if we are able to detect lung nodules, we can improve patients' prognosis. So we can guess that if we are able to detect to be more efficient to detect nodules, then we will improve patient prognosis in lung cancer screening programs. One question is it a good idea to use AI for a lung cancer screening? And this is the purpose of a study we are conducting in France. So this is a cascade study. This study is only including a woman, because we know that we are lacking data on women. And in this study, what we are assessing is a radiologist plus AI similar or equivalent to two expert radiologists? So can we replace two experts by one trained radiologist plus AI? And this is very important in terms of cost. And these are the preliminary results we have. So we have more than we have around 2,400 participants, and we know that we have a very high sensitivity, a very high specificity by using trained radiologist plus AI compared to double reading. In fact, we only had one false negative, and that's it. But also what we found is that the experts did errors, and this is an example of an error from an expert. This nodules here is very difficult to see and was not detected by the expert, by one of the two experts, but was correctly detected by AI. So AI would have been helpful for this expert. We can also use, or can we use AI to characterize nodules to improve patient prognosis? In fact, yes. If we use AI to do volumetry, so to calculate the volume of the nodules, it's what we do in a clinical routine, and this is very helpful. And this is a paper to show it, because when we are using volumetry, it's more accurate than 2D measurements, and we know that we will be more consistent to classify patients between patients that will need a follow-up CT scan, patients that are that have an indeterminate screening, or patients that have a positive screening. So to decide what to do with the nodule we detected. But in this paper also, what we can see is that even if it's improved the performances of radiologists by using AI volumetry, we also see that radiologists had to do manual tuning on this volumetry and to add some nodules that were not detected, meaning that AI was not perfect on its own, and it is a combination of radiologists plus AI, which was better than only radiologists. The second question is, can we use this computer-aided diagnosis tool I showed you that are able to predict whether a nodule is malignant or not? If we go back to the data I showed you, we know that the potential benign resection rate in the first study I showed based on deep learning was quite high, meaning that 20 to 30% of benign lesion will have been resected, so meaning that we will have performed unnecessary surgeries in this patient. So it's a high cost for these patients. And for the second paper, is the one from Google AI, is the one doing like automatic lung cancer screening. What we saw is that when we do what we do in clinical routine, meaning that we do follow-up for patients, in fact, we have the same performances as that what we obtain when we use this AI. So it's not the benefit from for the patient. So currently, there is no utility of computer-aided diagnosis tools. And one other problem with these tools is who takes the responsibility for errors. And this is very important, because if the tool says that this nodule is benign, but at the end it was a lung cancer, who is responsible for the decision to not do anything to these lung nodules? Last justification of using AI is to increase productivity, and this is a major claim from companies who are selling AI, is to improve efficiency, but also to improve quality. Why does it allow to increase productivity? Because it is better integrated in the workflow, and this is not related to AI, it's just related to a better workflow. And we now have access to these tools in our PACS system, so the system we use to interpret the images. We don't need to open different software, so we are not losing time. We are more efficient when we use this. But it's more efficient than previous scan, but than previous CAD system, but is it more efficient than not using a CAD system? And this is a very important question. And this depends on how you use it. If you use the CAD system as a second reader, meaning that you first read the images, like as usual, and then you read the result from AI, then you will not save time. It will cost you sometimes. So the second approach is to use it as a concurrent reader, meaning that when you open the CT images, you directly have access to the results of AI. And in this setting, you can save time. But how you save time in this setting? Just by decreasing your sensitivity, but you expect that the AI will increase your sensitivity. So as a trade-off, you will have a benefit. And the last possibility is to use AI as a first reader, meaning that you first give the CT scan to AI, and it decides whether you should read it or you should not read it to report it. And so you see that depending on how you use AI, you will or you will not save time. So you will or you will not increase your productivity. What are the perspectives of AI for lung cancer? The first one is to use AI to decrease the workload for lung cancer screening. It is using the AI as a first reader, so it's not validated yet, but this is a paper that's shown when you ask a technician to review the images using AI. In fact, you have a very high sensitivity to detect these lung nodules. So it's a way to decrease the workload for radiologists by making the technician reviewing images with AI. But one of the problems of this approach is that we know that AI is not perfect. So these are data from our lung cancer screening program. And what we found is that in some cases, the lung cancer was not detected by AI. Hopefully it was detected by radiologists. But will it be the same if a technician reviews the images, or will it be or if we only use AI, we know that we are going to miss some lung cancer. So AI is not perfect, and it's very difficult to decide how you want to use it. The second way to use AI as a perspective is to use automated reporting. And so yet there is nothing on chest CT, but these are some data on chest X-ray. So this is generative AI that has been applied and that has been trained on a lot of examination and then applied on also a lot of examination. And these are the results. So in this study, what they did is that they took some chest X-rays for which they had the report, and then they asked the AI to do a report, and they sent the exam also to a teleradiology company, and brings the report from this teleradiology company. And what we can find here, so this is a way to assess the quality of the report, and here the the quality of the report made by AI was almost similar to the one made by radiologists, and it was better than the one made by teleradiology. So AI can help. It's not as good as on-site radiologists, but still better than teleradiology. Last thing I wanted to show you is that in math, 1 + 1 is equal to 2, but in AI, it's when you use AI in a clinical routine, it's not always the case. And this is a very nice paper that has been published in 2024 that shows that depending on who use AI, you don't get the same effect. What they did in this paper is they asked 140 radiologists to assess chest X-ray, and these radiologists, they use AI, and what the author did is that they assessed how the AI impacted the performances of these radiologists. And what they found is that the impact was very heterogeneous. Some radiologists, they had the benefits from AI, so there was an improvement, and some radiologists, they had a worsening of their performances using AI. And they tried to check what are the factors that can help to decide who is going to benefit or not from this AI. And they found that years of experience, subspecialty in thoracic radiologies, or experience with AI tool did not serve as a reliable predictor of or positive impact of AI. And also what they found is that radiologists who had poor performances were not the one, were not necessarily the one who had the higher benefits from using AI. In fact, the only thing that was predictive of the benefits you can get from AI was the quality of the prediction of AI, meaning that if the prediction is bad, then the radiologist is going to worsen, and when the prediction is good, the radiologist is going to improve. And this is very interesting to see that the impact of AI on radiologists is not always the same. So in conclusion, we saw that there are many applications of AI in lung cancer research. The current clinical routine applications are limited to computer-aided detection system and to volumetry. There is a need for tools to improve radiologist efficiency and or patient prognosis, and maybe there are new perspectives to come with generative AI, but yet we don't have this kind of tools. Thank you very much.
Thanks a lot. Thanks a lot for your insights, Guillaume. I think I would like to highlight also that the audience can put comments into the comment stream so that we can pick them up during the discussion. But I would like to start with a few questions that came to my mind. And so one is that you highlighted kind of the benefits, but also the limitations of using AI in clinical practice. And I think that's something that's really picking up only now. But what I'm really curious about is your opinion in this relationship between AI and radiologists, right? So on the one extreme, it might be complete automation of tasks. On the other extreme, it might be just basically used in rare, very complicated cases. Can you say a bit about your opinion, how you think AI tools and radiologists will work together in clinical practice or not?
I hope they will work together. In my clinical routine, I use AI on most of the examinations. The main problem with AI is the cost, because it costs costs. You can say that it costs a lot or not, but it's expensive, and so when you use it, you need to have a benefit of using it, and this is the main problem. And this is why, in some cases, I know that some of my colleagues are not using AI because they are not confident enough in the results, so they don't want to pay for some things they will not necessarily use. But in my opinion, we should use AI as much as possible as a second reader, because we know that it helps for detection tasks. I think we should not yet using AI for characterization because it's not ready. Performances are not sufficient. Or for detection, we should use AI, and I use it every day.
Thanks. A connected question is exactly about this point where you say, well, it's ready for detection, but it's not yet ready maybe for characterization, and kind of telling us something about the complexities of what we see in the imaging data. But thinking a bit into the future, when we are optimistic about the developments, do you see a role of AI in helping with kind of complex treatment decisions because it can see things or characteristics in the imaging data that we cannot see right now? So my question is a bit going into the direction, we see something, we can teach artificial intelligence to recognize what we teach it, but maybe there is other information in the imaging data of nodules or kind of surrounding tissue that we cannot put a word on. Do you see a chance that AI can capture these characteristics that might be predictive for response to a certain treatment or for the kind of course of a disease that we cannot differentiate right now?
Yes, it's very interesting. I remember when I did my PhD a few years ago in an engineering school, like engineers were very keen to tell me that I was going to be replaced because AI was able to see things that I was not able to see. I'm not sure that there are information in the image that we are not able to see, maybe some, but very few. And years after, we don't have these tools that are able to see things we are not able to. So in my opinion, where AI is better than radiologists is to give a prediction and to put numbers in front of prediction. If you ask me, do you think that this lesion is benign or malignant? I will be able to tell you like, yes, I think it's malignant, or yes, I think it's benign. But it's very difficult for me to tell you like, there is 55 or 59% chances that it is benign or that it is malignant. It's AI is more efficient in giving numbers, but I'm not sure that it is far more efficient in things that are not seen by radiologists.
Got it. I think there is a phone ringing.
Yes, for it, my neighbor
This
and my
phone is ringing somewhere. Is this an alarm or is it just a phone?
It's a phone. It's not an alarm.
Okay, good.
Thanks. So I think that's and if I may, I would like to follow up on that, because what you just said, that sometimes these tools enable us to quantify kind of gradual changes or size or amounts, things that are in the imaging data that are hard to quantify by hand. And I think one thing that when I came to, my background is technology and mathematics, so very far away initially from medicine, and I always thought that the big kind of relationship question, so to say, is the relationship between AI and doctors and clinical doctors. But what I learned over time was that there is a huge world of relationship between different disciplines in medicine that are involved with coming up with the right diagnosis, delivering the treatment, guiding the patient on the path through different diagnostic steps, through different treatment steps. There is radiology, there is laboratory medicine, maybe molecular diagnostics, there is pathology. Do you see, Guillaume, any role that artificial intelligence can have in bringing these disciplines together, or in changing the role of these disciplines versus each other, because things start to become quantifiable, start to become measurable that were not measurable before?
Yes, yeah, I fully agree that there is plenty of room for AI because I told you about like just looking at images. Just looking at images, it's difficult to do better than or to see things that we are not able to see. But when it comes to multimodal information, meaning that if you want to combine CT scan plus biological data, pathology, then I think there is plenty of room for AI to being able to deal with this very complex data coming from very different sources and to build like very efficient model. And in the future, I spoke about generative AI, but I think one of the way to improve our use of AI is to use multimodal information, and people are working in this field.
Great, thanks. I wanted to, I have a couple of more questions for you, Guillaume, but I wanted to exploit the fact that Nicolas is in this podcast, and I'm curious about a couple of questions. And one of them is, which comes up very often in discussions, about the responsibility. What happens if there is an error in the diagnosis, and that happens, right? So there is no world in which there is 100% certainty, and these errors happen. What happens in this case? Who is responsible? There is the radiologist involved, there is the AI involved, there is the AI kind of developer, programmer involved. Who is responsible, and what's the prerequisites for this responsibility?
Yeah. Thank you very much, Georg, for this question. And unfortunately, I need to give the typical lawyer's answer, which is it very much depends on what has happened, right? So unfortunately, I can't give you one simple answer for all the cases. It very much depends on every single case. As a rule of thumb, and there's another point which is important, because unfortunately, or fortunately, as you want to see it, the European legislator has tried to bring some more light into this, because the European Commission proposed a specific directive on liability for AI systems about 2 years ago, but that proposal was skipped now. So we may not expect any specific AI-related regulation from the European legislator for the next upcoming year or two, I would say, as a minimum. So just general rules apply. And general rules apply means, as a first rule, in European systems of torts, there needs to be somebody who acted negligently. That's the first question to ask. So is there any negligence in the case? Was a specific doctor acting negligently or not when applying this or that system? And the question whether that person acting negligently is closely connected with another question, which is, what is state of the art in this domain? So did this doctor deviate from the state of the art? And whether or not the use of such systems is state of the art is, on the one hand, an empirical question. So it's the question whether doctors really use this, just like Guillaume is using it. But it's also a normative question, because it might be that there are standards of care and that there are soft law rules in this specific medical domain steering whether or not people should or should not use AI. So provided that there is a standard procedure in this domain, it is very likely that a doctor following the standard procedure and not doing anything but following the standard procedure is not to be held liable. So that's the one part of the question. The other part is, somebody produces those AI systems, and in many cases, it might be that those are to be seen in the near future, in the very near future, as products. And when it comes to product liability, then the rule of thumb is not necessarily you need negligence. It is sufficient that the product is put on the market, right? So putting something like, I don't know, a car on the market means that the manufacturer might be liable for damages coming out of the car, even if there was no negligence in producing the car. The interesting question now will be, who exactly is the producer in this scenario? So is it the person writing the software, or is it the person providing the hospital system? And in how far can those people try to exclude their liability in their relation to the clinic by a contract? That's the third answer to your question. It might be that contracts try to limit the manufacturer's or the producer's liability in this case. So long story short, if you are a medical doctor and you want to do research on this, this is a different topic, and you should very much, of course, follow the research standards in your domain. If you want to use it for treatment, the best option is to follow standard rules of care in your domain if you want to exclude liability.
Great, thanks.
I know, yes, that we have some colleagues in. I discussed with colleagues from other countries, which are very embarrassed by the fact that this, especially for chest X-ray, you can have this summary that shows what the AI found on the exam, and it is saved on our systems. And so, when you do the report, if you don't follow what is in the report from AI, they are very embarrassed that it is saved. And so, if there is a trial, then we can go back to what AI said. And if you decide that it is not a lesion, but at the end it's a lesion, then you are. It will be more difficult to justify in front of the law.
Yeah. But that's more a question of proof than of the legal part, right? So it might be that's correct. It might be that one of the consequences of the increasing usage of digitalization as a whole might be that data is better accessible for ex-post analysis. And it might then also be that errors are better found than they were found so long, right? This is true, and this is, of course, something that doctors need to take into consideration, but that's also true for any other profession, right? The more of our acting is to be recorded somewhere, the more likely it is that someone finds errors in what we're doing here. But not every error is necessarily negligence or a proof of negligence, right? So that it might also be that that was not foreseeable for any given doctor in that scenario, so that personal liability might still not be the case. But the problems, of course, increase for the doctors. That's true. Might increase. On the other hand, it might also increase. It might also be quite likely that there are less cases where doctors simply don't see the issue because of the reasons that you showed in your presentation, such as fatigue, right? So if I avoid an error because the system corrects me, that is also something to put into this analysis, of course.
I feel also, and I mean, I pose it as a question because I'm coming from the technical background, but so all of these systems, they come with a certain accuracy value, right? So that they present their sensitivity, their specificity, and since all of that is not 100%, there is a good reason why a doctor might disagree with the software in some cases and might say, well, the software says this, but I actually, given my knowledge, given my expertise, I decide differently. And that might be very well founded. There might still happen an error, but I still feel that that is within the scope of using the software so responsibly.
Yes, very right, Georg. And this is, I mean, on the one hand, what you're describing is a 2,000-year-old principle, which is the question whether somebody acted negligently or not needs to be decided by comparing that person with an average user of the system. So the more arguments you have that you followed or did not follow the system's recommendation because of your professional understanding of the issue, the more likely it is that you do not deviate from this standard bonus paterfamilias, as the Romans called it, so the standard figure of the average doctor. So that's one point to make here. So the more accurate you use the system, the better your chances are. The other point is exactly what you're saying is one of the arguments why product liability is such an issue here, right? So somebody puts this on the market, and this thing might be dangerous for the reasons that you are mentioning here. Just like, I don't know, a nuclear power plant, right? They are also dangerous and useful at the same time. And one of the inventions of the law then is to make people producing nuclear power plants liable even if they did not act negligently. So that's the core idea of product liability, and that's also one of the ideas that might apply here.
Right. Yeah, I think that's a very, I think, good direction, because I think it's discussed very often, and clarity there is, I think, extremely helpful. I wanted to But also Guillaume and Nicolas, if you have questions, please don't hesitate to chime in. I wanted to go a bit more into the direction of development of novel AI and development of new treatments, because like there is a long history of developing new treatments in medicine, but now there starts a new kind of phase where there is also development of new AI tools. And in my mind, that's always very similar to the development of new diagnostic tools, which is not a totally new idea, but which has been around for a while. I think one thing that's new is that the tools in this area of artificial intelligence are sometimes developed together with new treatments, or that's at least some perspective that we have, that we say, well, we can develop a new treatment, but it might be tricky to understand which are the patients who benefit from a treatment. So AI kind of developed together with a new treatment can help us to steer this treatment to the right patients and not waste time essentially with treating a patient with the wrong treatment and then switching treatment on later on. So Guillaume, for you, do you see that there is a role for AI in the development of new treatments, in kind of creating this quantitative evidence that we need in order to tell whether a treatment is working or not, and then later on to also develop the diagnostic algorithms together with new treatments? Or is that farther in the future, or is that something that you and the community in radiology is thinking about?
Yes, in fact, I think there are two possible applications of AI. We have many tools that have been published. Some of them are dedicated to clinical routines, such as lung nodules detection, but some other tools might be more useful not at an individual scale or at an individual level, but at a population level, meaning that they can be used, for example, to quantify whether this kind of lesion decrease or not in the population that's treated by this new drug. So yes, I think one of the major application of AI is to be able to deal with a large amount of data, a large number of patients, to quantify like phenomena on a lot of images to see what is the impact of a new drug, for example. So I'm convinced that it is one of the application of AI is to understand the disease and to assess the efficiency of new drugs.
Great. And I have one connected question to you, Nicolas. I think what Guillaume was just describing was also connected to the question of evidence, right? Evidence that something works, evidence that's needed in order to develop new treatments, but also to develop AI algorithms that need to be trained on data. And one of the big challenges I feel right now that we realize is a challenge is the diversity and the heterogeneity of the real world patient population. And there, of course, the European health data space and on the developments around that I think might have a very good impact on enabling the validation of and training of these tools on really representative data that does not capture only a small section of the patient population, but really a broad population that is for whom that might then be beneficial. Can you say maybe a bit on the closing of this session on your view on where we stand with the European health data space and the secondary use of data for the development, but also for the validation of these types of software and models?
Sure. So long story short, I mean, if you are into research with medical data in Europe in the last 30 years or so, one of the most important issues that you are constantly confronted with is that data is organized in silos. Every hospital is sitting on a set of data, and they are not really interchangeable and shareable. That's a very common problem. And the European Health Data Space Act, which is a piece of European legislation, it's a regulation, is an attempt to do two things. First, to make data more accessible for treatment purposes. So if you have an accident during your holidays and you need to go to the doctor somewhere in an area where you normally don't live in, that doctor should then have access to your treatment history, which is stored in your local patient file. That's the first idea. And the second one is that it should be easier for European research institutions to make data accessible for research purposes, for secondary purposes, which is treatment is the first purpose and research is the secondary purpose. And we have been trying to do this now for several years. We are very close to a publication of the European Health Data Space Act in the upcoming weeks or so. So it's just a matter of weeks now. The political agreement was already found. But then, of course, it needs implementation. It needs implementation in all the 27 member states, and it needs a lot of infrastructure, regulatory requirements, and all this. So I would not expect this to be directly beneficial within a few weeks or a few months, which is unfortunately one of the problems here, because the AI development is so fast that every minute that we are losing here in this competition is a serious loss in comparison with other economic areas of the world. So it will not, unfortunately, it will not be directly useful in the next weeks or months, which is a problem. However, one might expect, or one might hope, that it will help us, and it will help in particular European researchers to get better access for secondary use of data, with all kinds of follow-up questions coming. One of them in particular is in how far patients should or should not be allowed to opt out of this secondary usage, which is one of the key ethical questions coming with this European Health Data Space. So long story short, again, hopefully things will be better, but it's not a silver bullet.
Thanks a lot, Guillaume, for joining us. Thanks a lot, Nicolas, for inviting us. I really enjoyed the discussion. I hope it was also interesting for the audience. And with that, I'd like to thank everybody for participating and coming. And I'm closing the session. Thanks for having us.
Thank you very much.